We're here with Virginia Triant at the 10th workshop on adverse drug reactions and lipodystrophy. And we're going to be talking about the issues around what you presented on C-reactive protein.
So C-reactive protein it's an inflammatory marker, and many studies have shown that it's an independent predictor of cardiac risk for general populations, for non-HIV populations. It's, there's been a lot of debate, but it seems to be moving closer to be incorporated into cardiac screening guidelines. And studies have shown that if you have a normal LDL or bad cholesterol, but a high CRP, you're at equivalent risk for cardiac disease as if you had a high LDL. And this has been shown many times. The question that we sought to address is whether this would also be a relevant cardiac risk predictor in HIV populations. And it's an interesting situation because a lot of studies have shown that patients with HIV infection have higher baseline levels of inflammation, higher if they're not on antiretroviral therapy, but even on antiretroviral therapy, still higher levels, and have higher levels of C-reactive protein. So the question was whether, on top of HIV infection, if you measure C-reactive protein, does that add anything with respect to predicting cardiac risk beyond the fact that there's already a chronic, there's already an inflammatory state? So are they redundant, HIV infection and C-reactive protein, or could C-reactive protein be something that would be useful for the HIV population to stratify in terms of development of future cardiovascular disease?
So is it the quantity of the C-reactive protein that bears on the more likely case of response?
Yeah, it's the level usually. I mean, it's measured as, it's measured in a numerical scale. So it's usually how high it is, but there's usually a cutoff. And there, for a lot of studies use high sensitivity CRP, which we weren't actually able to look at specifically. That's a more specific marker, and I think levels higher than 3.8, or they're quintiles of risk, and above the highest quintile of risk in general population signifies an increased risk of cardiac disease.
So that may be of some consequence, but that's yet undetermined.
That's undetermined. And the result, do you want me to go on to the results?
Oh, yeah.
And so that was kind of the question, and what we showed, looking at a database of patients. We had about 70,000 patients within 2 tertiary care hospitals in Boston who, in the course of their usual medical care, had a CRP drawn. That could have been for any reason, actually, for perceived cardiac risk, but also for active infection, inflammation, because it's used to monitor those as well. So we did a model, and we looked at anyone who had a CRP drawn and showed that in regression modeling, CRP was independently associated with the development of a myocardial infarction, even when accounting for HIV. So they didn't, in a sense, cancel each other out. So what this suggests is, and it's kind of a global look at the process. We weren't able to say exactly what number is the cutoff. And there were important data like smoking we didn't have for all of our patients because it's a large database where this isn't electronically captured for everyone. But the results did suggest that there is potential to use CRP as a marker of cardiac risk to determine who's more likely to have a heart attack later on, and if there's an increased likelihood, then to modify risks more aggressively, like lowering the cholesterol level, smoking, physical inactivity, things like that.
So this marker might be evaluated again, or it's more studies to become more profoundly associated with this as a.
I think certainly. These are really interesting results, but it's one study of a database that has a lot of patients, but was not a prospectively designed study to address this. So I think
it didn't have the risk, the smoking risk in there. Could confound to some extent.
Smoking could, and we did kind of a sub-analysis of some chart review looking at smoking in some patients, and it looked like smoking wouldn't affect the results of the study, but we can't, I can't say that with 100% certainty. Yeah, it would be very important to know. So I think, I think it's really interesting and promising, but I think more studies will have to be done to definitively say, should we check this? Should we be checking this for every HIV patient?
In the conference that we just now almost concluded,
yes.
Did you see anything else? I mean, it seems to me like markers are really important today, and this is yet another that looks like it's on the cusp of being of value. Did you see others that in your in your exposure to the conference as it was?
Well, I mean, this one, CRP receives a lot of attention because it's one that's actually easily measurable and testable. I think there are a lot of markers of inflammation and coagulation, but the assays aren't so good to do in usual clinical practice. So one of the things that they say is to test a result is, is that the assay has to be something that you can actually use that's practical. Because if it's something that requires some in-depth lab evaluation, it's not going to be useful for patients.
As far as
CRP is the most useful. Sure. I mean, others that have been highlighted in the SMART study and in the DAD study as possibly related to either treatment interruption or to abacavir use were D-dimer, IL-6, and then in high sensitivity CRP. But D-dimer can be routinely measured in practice, but it's not specific, meaning it can be elevated in a lot of different situations. And IL-6 is a little harder. We don't usually measure that as a routine lab, but maybe it would come into use in the future.
Well, I thank you so much for bringing this to our attention, and we'll be watchful.
All right. Well, thank you so much.
Thank you.